So that's Jazini from Reston, Virginia. I want to thank everyone, the NASS committee, for inviting us here today and acknowledge my co-authors, as well as the National Spine Health Foundation for the help of the study. As everyone knows, the opioid crisis is a national emergency and has accounted for more than 42,000 deaths in 2016 alone, with estimated 40% of these deaths being due to opioid prescription. Enhanced recovery after surgery was a program and protocol developed by colorectal surgeon Dr. Kale out of Denmark. And he noticed that there was a lot of variability in length of stay after open colectomy. And he wanted to understand what are the best practices that you can put together into a protocol in order to effectively decrease the morbidity associated with surgery. The adoption of ERAS to spine surgery has been very slow, and it's primarily due to the fact that there's specialty-based modification that need to be made. ERAS involves multiple steps from the pre-hospital phase, pre-op, as well as the intraoperative and post-operative phase that has to do with patient education, carb loading, multimodal analgesia, volemic control, as well as post-operative management to help both get the patients out faster, but also to reduce opioid consumption. And the focus of our study is how do we decrease that consumption both before and after surgery. The purpose of our study was to evaluate the implementation of ERAS for adult spinal deformity surgery and understand whether the implementation of this protocol in the early phase of this implementation of this protocol helps to reduce opioid consumption. And we have hypothesized that it would. Here's what we did. It was a retrospective study of 50 adult spinal deformity patients. We looked at 6 months before ERAS was implemented as well as 6 months after. We had 28 patients in the first group and 30 patients in the second group. The patient breakdowns showed that the average age, number of levels, views, whether it was stage or non-stage, was similar between the two groups. Our primary outcome measure was opioid use, measured in morphine equivalent dosage. We looked at that for the in-hospital stage, 90 days post-operatively, and we also looked at the sub-cohorts of opioid-naive versus non-opioid naive. We also looked at PCA use. That was a primary focus of this protocol to reduce the consumption of IV narcotics, length of stay, post-operative day of ambulation, as well as Foley removal after surgery. Here's what we found. When we looked at the in-hospital opiate use between the two groups, you can see that in the post-ERAS group, it was decreased. However, this was not significant. There was a downward trend. The same story was found to be true with the 90-day prescription that was given to these patients. There was a decrease, but this was not significant. When looking at the sub-cohorts between opioid-naive versus non-opioid-naive, there was significantly less opioids given to those that were opioid-naive. This was the same when you looked at how much prescriptions these patients were getting. If you weren't taking opioids before surgery, you also took a lot less. Looking at Foley removal, there was a significant decrease when the Foley was removed from around 3.5 days post-op to less than a day post-op. The PCA use was almost completely eliminated. The length of stay was slightly decreased, but it was not significantly different. The day of ambulation was significantly decreased from about a day to less than a day. This is the first analysis of ERAS after adult spinal deformity. This is our early experience. We were able to really get down on usage of PCA. As many of you know, PCA is not a very good way to control pain. Patients will fall asleep and wake up in pain, and it starts this cascade where they're not satisfied and they're not really getting good pain control. And so our goal was to convert that into long-acting and short-acting pain medication to help reduce their pain, but also to keep them in a more steady state. In terms of ambulation and fold removal, our results show that we were doing a good job in terms of getting patients out faster and also getting the Foley out sooner. We did not find a significant decrease in opioid consumption in the hospital as well as the 90-day, but there was a downward trend. We think this is due to a small sample size. Significantly, the pre-op opiate use, as shown in some other study, was a significant factor in how much opioid consumption patients had. There was more than 400% increase. And we think this is an area where we should target preoperatively to help patients wean off their opioids before having surgery. There was no significant decrease in length of stay, but again, I think a lot of it has to do with the sample size. Our goal now is to obtain more granular data on how many pain prescriptions, pain medications patients are taking. As you know, a lot of times you give patients 90 tabs, but that doesn't mean that they're actually taking all those medications. And so we're going to do a much more fine-tuned data analysis of how many of these pain medications these patients are actually taking. We're also refining the protocol to account for the surgery size, but also the patient characteristics to be more patient-centric in terms of how this protocol is implemented. And we're doing a multi-center study across more than 20 centers to evaluate what are the best practices and to develop a more unified ERAS protocol. Thank you very much.